Welcome to the last learning objectives for today's class, where we'll be discussing ACA and a number of vulnerable population. So, starting with racial and minority groups, we want to look at what was the situation pre-ACA and then look at what became the situation post-ACA. So, pre-ACA, a lot of minority groups, Black, Hispanic, and indigenous populations they had much higher uninsured rates compared to the white population. Post-ACA, especially Medicaid expansion narrowed this disparity because it's expanded coverage to more people. So an example would be that uninsured rates among the Latino communities fell from 32% to 22%. So the ACA also brought with it the federally qualified health centers, FQHCs, and which provides a kind of secure safety net for those who are not able to receive proper care elsewhere. So this health centers provided low cost care to high risk minority groups. Just to kind of clarify, it does not mean that they only provide care to minority communities. It's just that there were many minority communities that were low income. They were much more than in terms of percentage. That it affected minority population disproportionately to white population. So, with the federally qualified health centers, they then had more high risk minority groups needing their services. So these health centers were funded under ACA in order to expand primary care. They provided maternity health as well as provided chronic disease management. So under this program, over 25 million people were able to be served annually, and the majority of the population that received care from them were racial and ethnic minority population. So, even though it was all great, as usual, it doesn't mean everything was peaches and cream. With ACA, even with ACA, there are still some challenges that either happened as a result of ACA or persisted despite ACA. Starting with the non-expansion states and also there being a coverage gap, the states that refused to expand Medicaid, it now meant that more ethnic minority groups were uninsured in them compared to expansion states. They also had more of people who fell under the coverage gap, in that they were too rich to qualify for Medicaid, but they were too poor to be able to purchase their own health insurance. So they kind of fell within the coverage gap, and this affected individuals in non-expansion states than it did in expansion states. There were capacity issues with the FQHCs, in the sense that there was high demand for them, which then led to long wait hours, and therefore having underworked and understaffed clinic and underworked staff. So, as even though the centers were funded, uh, there were still some funding challenges, and this affected some areas, particularly rural communities or very low income populations. The problem of implicit bias and structural racism was not adequately addressed by by ACA. Even with ACA, minority groups are still more likely to receive low quality care, even for those who are insured. And this is the same whether they live in expansion states or they live in non-expansion states. Disparities in pain management, referral, and diagnosis is still something that has persisted. The ACA did not directly address implicit bias in medical training or practice, therefore, did not make sufficient effort to address this problem and health outcomes that are a result of this. So now coming to women's health, pre-ACA, most insurers excluded maternity care from their plans, and then you had situations where women were charged more premium than men, even though they were receiving identical insurance benefits. With post ACA, maternity care was now required of all insurance plans and to provide maternity care, contraception, as well as preventive screening. ACA also expanded cancer screening, including mammograms and pap smear. And also, insurance couldn't charge higher premium based on gender. Under ACA, as a result of them requiring them to provide maternity care and all the rest of it, there was improvements in prenatal and postnatal care, particularly for low-income women who were now eligible for Medicaid. As you can see in Table 2, the eligibility criteria for conception to birth is quite high in a lot of states, and so up to 300% federal poverty level. So you could imagine there were much more women who became eligible for Medicaid. So, and this led to better health birth outcome, reducing infant mortality rates, particularly in expansion states. And women were able to gain free access to contraception, and therefore leading to better health family planning. Same with racial and ethnic minorities, there still remain some challenges post ACA, one of which being that abortion access was not covered under ACA. So when Roe v. versus Wade was repealed, that left a lot of women very vulnerable, particularly in Republican states or states that had very strict abortion laws, and we're penalizing women for seeking abortion services and also providers for providing abortion services, and even for insurance who were in the ACA marketplaces, a lot of them stopped providing that service to women who needed it. Coverage gap in maternity care in expansion states still very much persists with low-income women who were uneligible, who had fewer eligibility to expansion in non-expansion states, and with non-expansion states, higher maternity rates is typically higher because there is less access. So provider shortage, particularly as it relates to OBGYN, remains, particularly in rural communities or in very low income communities. And so what happens is that many women still struggle to access maternity or reproductive care services. So with LGBTQ, section 1557 under the ACA provided anti-discrimination protections for members of the LGBTQ population, with discrimination based on sex, gender identity, and sexual orientation being prohibited. So this allowed LGBTQ individuals to challenge providers that denied them care. So with expansion and also the marketplace coverage, many LGBTQ individuals were able to have health insurance because many people in this community live in poverty or they lack employment-based insurance. So with Medicaid expansion and subsidies done available through the marketplace allowed more people in that community to have insurance, and thereby reducing uninsured rates. So there is high rates of depression, anxiety, and substance abuse in the LGBTQ population. So with ACA coming in and enhancing and ensuring mental health parity laws, that it then reinforced those mental health laws, and thereby requiring equal treatment for mental health as well as physical health. Um, Through the ACA, as part of the essential health package, essential health coverage, you had HIV prevention and PrEP, being available, with ACA mandating HIV screening as part of preventive care, and also as a result, increased access to PrEP for high risk groups. So, for the challenges, the post ACA challenges, there is a inconsistent enforcement of Section 1557, where protection weakened depending on different administrations, very similar to the cost reduction subsidies that I spoke about in previous learning objective. So you can look at Table 8 to kind of see how different administrations changed how this Section 1557 was enforced. So many LGBTQ individuals face denial of care depending on the administration that is in power. And also, coverage for gender affirming care was also spotty, with many insurance refusing to cover hormone treatments or gender affirming surgeries. And there being limited providers that are trained in LGBTQ healthcare. Barriers to LGBTQ still very much persist in rural areas, with LGBTQ individuals that live in rural areas having to face barriers that come as a result of the identity, their sexual identity, as well as geographic limitations. So they have this a compounded challenge of being both problems with LGBTQ identity, and then problems with living in an area that have reduced access to healthcare. And then so it affected healthcare access, social acceptance, and their economic stability. So, and there are very few culturally competent individuals, because a lot of rural providers do not receive any training in LGBTQ health needs, which then leads to continued implicit bias or sometimes outright discrimination. So this is Table 8, and then you can look at how different administrations have interpreted the Section 57 protection, and how it has impacted those vulnerable population. So, lastly, to discuss impact of ACA in rural communities, pre-ACA, there was very high uninsured rates in rural communities, with most rural communities being uninsured because there are a lot of people that were low income in rural communities, and their Medicaid eligibility being much, much lower than it is now. It then meant that many of them did not have health insurance, and also there were fewer employers that were providing employee-based insurance. And this is because, and so without coverage, many rural residents, either delayed care or had or avoided medical care entirely. So there's also limited access to providers, because rural communities typically struggle with attracting providers, and so there are fewer primary care doctors, specialists, or community or hospitals in rural communities. And then some of the hospitals there, kind of close or have reduced services due to financial instability, and then what happens, you would have patients having to travel very long distance in order to receive care. Other challenges that existed due pre-ACA was there a lot of rural residents that did had to have very high out-of-pocket payments, which led to many of them having medical debts, and there were fewer insurance options in rural areas. And when they had very high premium. And then, rural communities, had some challenges with mental health or substance abuse, and there were very limited mental health services in rural communities. And these communities were had hits with the opium crisis, and with there being few treatment options, it then meant that it affected them much more than it would have if they had more treatments. So post ACA, with the expansion and marketplace coverage, there were now more low-income individuals in rural communities that were now qualified for coverage, and the insurance agencies also provided new and affordable private care options. This then led to a drop in rural communities' uninsured rates, particularly for states there where, states that expanded eligibility for Medicaid. And then you had essential health benefits that were enacted, and therefore meant there were more mental health services available, also substance use treatment, and more preventive care. Maternal health also became a required benefit for insurance plans, which improved maternal and infant health in rural communities. And then with the chronic disease management under ACA, it also improved coverage and screening with in rural communities. So there were more funding for rural hospitals, one of which happened through the federally qualified health centers. And then you had the prevention and public health funds that meant that more community health centers opened because of the funding that came from this program, which thereby reduced travel distance for care. And also, because of that, there is a lot of expansion in rural hospital programs, which helped stabilize hospitals that were struggling. Telehealth really expanded access to specialists, and which made it possible for rural residents to be able to receive care at their homes without having to travel long distance, or also having to struggle with having health providers that were in network for them. So it thereby led to increase in mental health services, substance use treatment, as well as chronic disease management, and also reduced transportation barriers, especially for those living in isolated areas. So, as you know, we've been talking about it, there's still challenges post ACA. Non-expansion states, I've talked about it so much, it still left a problem for non-expansion states, with many rural residents in non-expansion states still remaining uninsured because their eligibility for Medicaid is much, much lower than expansion states. And then rural communities still kind of struggle financially with Medicaid, with non-expansion states, because there's less health budgets in those states, and also fewer benefits as well. The shortage in providers is still a persistent problems in rural areas. Rural areas still lack sufficient primary care physicians and specialists. There being a higher demand for mental health, especially with telehealth, also meant that there are more people who needed these services. However, there are fewer available providers in order to serve the demand. And there is limitation to their being able to use telehealth, with there being broadband barriers, with many rural areas lacking high-speed internet, and thereby limiting their access to virtual care. And then older populations and low-income individuals are still struggling with being able to use technology, because some of the services are, telehealth are not so simple. It's not as easy as making the phone call. So you have to log in, you have to create accounts, which can be quite challenging for the older population, or those who are low income, or those who have not had, advanced education. So now that we are done, talking about how ACA impacted vulnerable populations, both in increasing their benefits as well as the challenges that they brought in. I just want to finish this module by discussing essential health benefits. I talked about it in previous learning objectives, but just kind of want to emphasize it a little bit, since it's a very core aspect of the ACA. So before ACA, insurance could deny coverage to key medical services, and many insurance excluded maternity care, mental health, and prescription drugs, and which then meant that patients who needed these services faced high out-of-pocket payments. After ACA, there was an establishment of a set of essential health benefits that all individual marketplace plans, Medicaid expansion plans, and small group employer plans, including employer-based insurance, had to cover. So they had to cover it in order to be compliant with ACA, and they had to do it without lifestyle or annual limits. So there was no cap in the amount of services you can receive for those services. So the essential health benefits include 10 categories of services that are all the plans are mandated to provide in order to achieve comprehensive health care, and also to protect consumers from inadequate coverage. So these are those categories. So there are 10 of them. I've kind of listed in terms of the categories and covered just a little bit of the services that is covered under them. However, I had linked what essential health benefits in previous slides. If you want to understand more what is covered and what it means, please go back to the slide and go into that link that I provided so that you can read more about it. So this is the rest of the categories. So this is where we end for today's class. I have been able to really talk about ACA as comprehensively as possible, so that you get a really good understanding of what ACA is and some of the provisions that are under ACA. So I hope this was educative for you. If you have any questions, please don't hesitate to use the Q&A board to seek further clarification. Do have a lovely day. Bye.